So that's a meniscal tear. This is me looking into somebody's knee. This is a left knee, that's the medial meniscus, posterior horn. And when you look on the MRI scan, you may see a line, it may be slightly unimpressive, but if you do an arthroscopy, you actually look inside and you can probe, so you can see it for real, you can probe it, you can see whether it's, you can feel and see whether it's unstable and how bad it might be. Now, that particular meniscal tear was a tear in somebody who was an older patient. The reason I'm poking and prodding it for a while is to get a really good feel for how extensive the tear is, whether it's a simple tear, whether the tissue's degenerate, whether it's likely to be repairable. And that's largely an intraoperative decision. You can get a pretty good idea beforehand as to the probability as to whether a tear is repairable. A lot of the time, you don't actually know for certain until you get in there. So that was irreparable in a patient with a very symptomatic knee, complaining of sudden sharp pain, painful clicking, catching, giving way, locking, those kind of symptoms. And so that's what the knee looks like once you've trimmed the meniscus. So you've trimmed away the torn tissue, you've got it back to smooth, stable tissue.
Myofascial trigger points exist in muscle that has developed an abnormality in which there is a well-defined tight or taut, T-A-U-T, taut band of muscle. We say a contracted band of muscle, but I think that's not true. I think it's edematous. But in any case, it's a hardened band of within muscle that prevents the muscle from lengthening. But it also means that that muscle is shortened, and that muscle can constrict and compress other structures. And the one structure, of course, of interest to me as a neurologist is the compression of nerve. So clearly, nerve entrapment can occur from a mass of any sort, whether it's a bony mass from arthritis or a tumorous mass, an inflammatory mass. But what is most common, I think, is a constriction of the nerve by an overlying muscle.
So now we look at cuff integrity tests. Again, as I've said, empty can filter, we cannot be specific about tendons that are irritable. Remember, I'm testing the whole cuff. But again, if I'm seeing something significantly weak and there's been a history of trauma, then these tests can be slightly more reliable. So if I've got a patient and I'm testing, if you just push out into my hands, sorry, Susie, that's great. If you push into my hands, I'm looking for obviously equal power. I'm looking to see if she can push out. Again, that's testing more posterior cuff. I quite like the belly test, which is testing more of your subscap. So if you push into my hand here, some people use the Gerber's test where you lift the lift-off test. Again, I tend to find that's quite uncomfortable to test. So I tend to quite like that test just to see what the subscap's doing. And again, you can then take them into these more positions. But again, remember, we are not being specific with these tests. These are not sensitive and not very specific. So they don't always have their value, but resistive cuff tests should be used just to check for cuff integrity.
Okay, so at the moment you're talking about cuff integrity, but we've got to rule out other things as well, haven't we? So do you use a scarf test perhaps?
Yep. So scarf test is obviously quite useful for acromioclavicular joint. If I turn you to the front, that might be easier to see. So Susie, if you can just take your arm across your body. But again, what also are we compressing there? We're compressing not just the AC joint, we're also stretching out areas of the neck. We're also stretching out the areas around the back of the posterior capsule. So again, not great sensitivity and specificity for AC joint pathology either.
But won't you get more specific pain around the AC joint?
Absolutely. So if you're looking more of an AC joint pathology, you'll get more they'll tend to come in and say, gee, I feel the pain's more here, whereas cuff patients tend to say they get more epaulate pain, okay. And biceps patients tend to say, oh, I'm getting pain or going down to my biceps area. But again, not so specific, but absolutely, scarf test has its place, absolutely.
So the important thing is, if you can preserve the meniscus, then you should. So if a meniscal tear is repairable, and these tend to be tears in younger people, so under the age of 40 with an acute traumatic tear, and that's quite different, a very different thing from an older person with a spontaneous degenerative meniscal tear, two different things. although there is crossover in the middle. There's that, if you pardon the pun, there's that grey zone in the middle. But if you have a younger person with a sports injury and they've torn what was otherwise previously a normal meniscus, then you should do your very best to repair them. But even in the hands of somebody who's really into knee surgery and really into arthroscopic repair, so which is like my practice in London, I'm lucky that I have a lot of younger patients, B, a lot of patients with sports injuries, and C, they get to see me quickly. So even in the hands of an enthusiast, and I've done plenty of research into meniscal repair, meniscal transplantation, still only roughly a third of the meniscal tears that I see and that I operate on, only about a third are repairable. That means 2/3 are not. If you can repair it, then it's a crime, or it's a little bit silly not to repair it. You should, because of the long-term consequences of trimming. But if it's not repairable, and if it's too symptomatic to leave alone, and that's a very important caveat, well, then you're going to trim it. And if you trim it, you take away as much as you need to get the remaining tissue smooth and stable, leave behind as much as you can.
Now, the interest in the pronator teres muscle comes because the median nerve passes between the two heads of the pronator teres muscle. So now the pronator teres muscle has a humeral head, which arises from the medial epicondyle of the humerus and then inserts on the radius. The other head, the humeral head, by the way, is the largest head and more superficial. The deeper head of the pronator teres is the ulnar head, which originates proximally on the ulnar bone, on the ulna, and then attaches to the radius just below the supinator muscle, and then the humeral head attaches just below the ulnar head of the pronator teres muscle. So there are two muscles that are distinct that both have the function, and you can see for yourself if you have fixed the ulna and the humerus and you contract the pronator teres muscle, you're going to roll the radial bone or the radius over and medially to the ulna, and you'll pronate the forearm, the wrist, and then the hand. So, and which now the pronator teres is not the major pronator muscle. The pronator quadratus in the wrist is, but it is a potent assistant to the pronation of the forearm. But the main point here is that there are two heads, and there's a space between them. And the median nerve passes between the humeral head and the ulnar head of the pronator teres muscle and can be entrapped.
So some of us out there would have heard about the wonderful work that Bobby Ainsworth did around anterior delt programs. So when we have got a massive cuff tear that's involving supraspinatus, infraspinatus, and subscapularis, we are in tricky situations. We know that this exercise, which is called the anterior delt program, has been shown to be more useful for patients that have infraspinatus, supraspinatus, but still have subscapularis intact.
Right.
So again, mixed research going on. There's still a lot more we need to do around how we manage those lovely patients that can't be repaired.
Yeah.
And they've had a massive cuff tear. So that tendon has retracted, the surgeon can't find it, it's got fatty infiltration, we won't be able to pin it back. So again, these are the exercises that I would use. So I tend to start ideally supine. That's the way that Bobby Ainsworth, who started this whole program, said to lie them down so they're relaxed. This is a good position to start. And I would then get the patient to just bring the starting position is to help assist it with this one. And you
Which is the injured shoulder?
Yes,
here.
this is the, sorry, this is the injured one. And you're going to passively help the shoulder up to that position. And then you're going to extend your elbow, working that anterior deltoid, and then bringing it back down to center, and then slowly lowering it down. And the idea of this is what you've got to remember is we haven't got that force couple anymore working. So what the anterior deltoid is trying to do is to provide any form of elevation to the shoulder, because these are the patients that come in classically with very little movement. So we're going to try and engage those muscles and see if we can help by doing that. Now, if they can do it in that position, then they don't need to use that arm, then they can just do it on their own eventually. Hold the arm there, Susie, slowly extend it up, keep it there, bring it down, and lowering it down again. The next progression, as we always say, Stephen, we're trying to progress the patient, you're going to hold the arm there, you're going to work at holding it there, counting it to 10, circling it one way, keep your shoulder centered. Again, patients with this cuff tear, you'll start to see that they start to drop. They start to maybe grimace a little bit and they get tired. So again, it's all about watching your patient, watching how they're focusing. But what I'm looking for here is a nice centered humeral head and not this classic hitching of the shoulder. So again, you do need to watch how they're moving.